82-year-old male with a history of diabetes, first diagnosed with pancreatitis in January of this year. CT.
Hi there. So this is I'm here with Interventional, and we have a lady who I have known for over a year now, who came in the past with dilated bile duct. We've done an ERCP and noted a polycapillary stenosis, and biopsied her ampulla, and actually she had an adenomatous tissue there, so we proceeded with an ampulectomy, at which time we had performed biliary sphincterotomy as well as a pancreatic duct sphincterotomy. That was about a year ago. All of her rushings and samplings from her both ducts have been negative. Now she comes back with some epigastric pain, pretty significant epigastric pain, postprandial, constant radiating to the back. She has normal pancreatic enzymes. However, on her imaging, she now has the dilated pancreatic duct up to about 6 to 7 millimeters. So we had brought her back a little recently for a repeat ERCP. We were able to get into her bile duct again and repeat sampling, which has all been negative, but now we were unable to get back into her pancreatic duct at that time, thinking possibly restenosis from the prior sphincterotomy. So now we're down here. At the time I placed a covered metal stent, which we're looking at now. And the thought is to maybe do a EUS guided access into the pancreatic duct.
Okay, good. So let's first of all take a look at the ampulla with the duodenoscope, and we have to remove this biliary stent as well, because if we're going to do an EUS guided rendezvous procedure to access your pancreatic duct, and hopefully we'll be able to get our wire across, but we don't want that biliary stent to be blocking the path, our ability to pass our wire across into the duodenum. So I'm now going to turn my back to you, and I think I'm going to have my back to you for the rest of this because of where the camera is located. So let's pop through, and actually I'm in the duodenum now. Do you have the endoscopic image? Yes, I think so. So you can see here that actually this stent is partially ingrown here at the distal end. Fortunately, you can still see sort of the basket. This is a wall flex, right? Yeah. So the wall flex is nice because it has this metal handle, if you will. I call it the basket handle, and this is what we can grab to pull this out. So even if the stent migrates up into the duct, you can put a rat tooth forceps into the duct, and you can grab that basket handle, and it'll collapse the stent very nicely. So let's open up the rat tooth now. I've already inserted that, and we're going to try to avoid grasping too much of the tissue. See if we can orient the rat tooth a little bit so that we can just get the basket handle. So you can see the handle there slowly close. I'm intentionally not pushing too far forward. Keep closing. This is a very large rat tooth, but I think I've got it now. And the assistant's going to hold this firmly. Now remember, it's a bit ingrown. It's a fully covered stent, correct? So it should come out, but what I'm going to do now is I'm going to lock here. And I was saying earlier that we probably don't need fluoral, but in this case, actually, we should use the fluoral so that we can monitor the removal of the stent. I'm just going to hold the stent. I don't feel comfortable. Well, let me see. Actually, let me see. Often you can just pull this right up into the working channel, and you don't even need fluoroscopy. But let me see if it goes easily. We don't want to damage the scope, but I can tell you that you won't. You can pull this stent usually through the working channel without damaging it. But if you have resistance, as I just encountered now, you can see the little pus or so coming out here, draining. If you have resistance, then obviously never pull against resistance. So what I'm going to do now is I'm going to lock the forceps to the handle, and now we'll switch to the left pedal or right pedal? Left?
This one? The one you're doing.
Okay, good. Right one. All right, so I'm going to now, we have to bring that down just a little bit.
You unlock the...
So just a quick moment so we can get the fluoral in position, and then we'll just watch the removal of the stent with fluoroscopy. We should see it pull out very nicely rather than trying to pull it into the working channel. But as I said, usually you can pull the stent right into the working channel. Just pull it right out. That way you don't have to re-intubate the patient again.
Ken, when the stent has migrated up into the duct, what's your favorite trick for getting it out?
Rat tooth. Gratitude, that works the best, absolutely. Then you look under fluoral, of course, and you open the forceps where that basket handle is, and that's usually pretty easy to catch. When you can catch that, see, I'm in the long position. I could not go in the short position, but here we are. You can see the stent. You can see I've grabbed the distal end, and now I'm just going to pull out. This is going to first shorten the scope, right? And now we should see the stent come out. There it comes, all right? So it's out. So obviously I have to pull this all the way out of the patient, and let's see here, I've got a little bit of resistance, so I have to be careful. Okay, it's coming, all right, so we'll have the stent now. Well, then we'll take that off. I'll push this out for you. Do you have it? Almost, okay, let me push it a little further. Okay, good, all right. Close the forceps again, and then we'll pull the forceps out.
Are we going to send that for psychology?
Yeah, I think we are going to, even though she's had numerous sampling of her bile duct, I found in the past that there's actually quite a lot of tissue that comes sometimes with these fully covered stents when you remove them.
So what I can tell you from experience, having done a lot of ampulectomies, that stenosis of the pancreatic orifice is not that uncommon. I've seen it a few times. Usually we don't do a pancreatic sphincterotomy, but we'll place a pancreatic stent to prevent pancreatitis. But after ampulectomy, there's a risk of that opening, despite that stent, of stenosing down. So here you can see the ampulla. You can see all of this, what I think is just, regenerative hyperplastic tissue here.
And this has been biopsied.
And it's been biopsied, and I don't think it's worth probing and trying to gain access to the PD. That was attempted before and failed. So let's just go right to EUS now. So we'll suck out a little air in the stomach and pull out and switch out for the therapeutic EUS scope.
And I apologize if you covered this during your talk, but is there a minimum PD duct diameter that you want before you consider an EUS guided rendezvous?
No. So, for example, just last week I had a patient with pancreativism, recurrent pancreatitis, and the pancreatic duct was normal. It was not dilated. But I could not even see the orifice to the minor papilla,
right,
although her MRCP clearly showed pancreativism. And of course, I attempted to find the minor papilla. We gave secretin. We did chromoscopy to try to look for the minor papilla. All failed. So then I had to resort to doing an EUS guided approach, anterograde, and the duct was 2 millimeters. In this case, I used a 22 gauge needle. Of course, a 19 would be difficult. 22 gauge needle, and then I passed the Pathfinder wire, a .018 wire. You can use also the Roadrunner wire. So there are a number of .018 wires. There's actually a new wire that Boston is coming out with called the Navy Gold, which I hear is a very nice wire. It's very stiff. So despite the small diameter of .018, it's a very stiff wire, so you can instrument nicely over it. At any rate, we were able to get the Pathfinder wire to cross the Santorini, the minor papilla, and then we completed the rendezvous. So the quick answer is no, and a non-dilated duct by no means excludes an obstruction of the duct. Of course, we sort of think of the duct as dilating up if it's obstructed, but this duct was not dilated, but clearly she had no drainage from the minor papilla. Just waiting for an endoscopic image here, and then I can pass the EUS scope. And what we're going to do is just very quickly look from the duodenum at the pancreatic head, just to be sure we're not overlooking some mass. That was done before, so I don't expect to see anything. And again, I think that her story is entirely consistent with a pancreatic duct stenosis, or I should say orifice stenosis.
I'm interested quickly. I think that's a great indication for this procedure, and we've all had patients with pancreatitis and divisum. How successful are you with that?
The rendezvous procedure for divisum?
For divisum, yeah.
I've had a number of cases. I don't actually try too long trying to get in. When cannulation of the duct of Santorini is challenging, I'll go to rendezvous pretty quickly now.
Wow.
And I've been very successful with that. I think that's a great indication for the rendezvous. Now, for some reason, we're not getting the EOS image for some reason. So just bear with us for just a moment. I got it completely deflated. There's something wrong with the scope. It's really dark. Yeah, there's something wrong with the scope. So let's switch out for a different scope. Now there's something wrong with this scope. It's very dark. And we've adjusted the brightness and everything, and that's not changing it. So we'll just pull this out so we can discuss some more. So let me just tell you what our options are here. Okay, what I'm expecting, what I'm told, is that the PD is quite dilated, right?
Correct. You want a forward view?
You can use a forward view, sure, yeah. We'll use a forward view scope.
Yes.
Do you know the forward view scope from Olympus has recently been released with the advantage
Let's get
that
the
you
forward
have an
viewing.
overlap of your ultrasound scanning field and your optical field. So your endoscopic field and your ultrasound fields overlap. So now you have the ability to look with ultrasound, see your target, and then, for example, if you pass your needle into your target, when you look with your endoscopically, you're going to see that needle right in front of you. So we're that much closer to really the ideal hybrid scope that combines endoscopy and ultrasonography in the scope. So I think this will be an advantage for those of us that are doing a lot of interventional EUS, because you definitely want to be able to have a good endoscopic visualization in conjunction with your ultrasound-guided intervention. So we'll try that out now. That scope, by the way, is a therapeutic scope. It has 3.7 millimeter channel. It has another advantage. It has a water jet channel, so you can irrigate, something you cannot do with the curved linear array echo endoscope. Both the diagnostic and therapeutic do not have a water jet channel. That means if you want to irrigate, let's say you have some bleeding or so, then you have to flush it, manually through the biopsy port. So here you can hook it up to your water pump and you can irrigate. We found that very useful because we do all of our glue and we use coils as well. Our coil gluing of gastric varices, we did that previously with the forward view scope. That scope then was just a prototype under evaluation, and now we're getting that back again because it has the advantage that when you do have some bleeding, you can very quickly wash away any blood. Is it ready? Yeah. Okay, yeah, all right. Okay, so it looks like we won't be using the forward view. So that water jet channel, what the forward view doesn't have is you don't have a balloon at the tip. There's a plus and minus to that. The minus to that is if you're in the duodenum, sometimes we use that balloon to anchor ourselves when we go into the short position so that, oh yeah, now we have the image. So this is working. I do need a little endoscopic view though, so I know where I am. Here we go, yeah. I'm sorry, yeah, you did have it for me.
You want that?
Yeah, back, yes, sorry. All right, so you'll just see my back then, so I apologize. But we'll just take a quick look here to see, and it's sort of, yeah, so I just want to show, I think this is the bile duct that's right up here. You can see the cystic duct come off of it. You can zoom in, please, one. So that's right there where the cursor is the bile duct. And you can see the cystic duct join the bile duct right there. And then you can follow, there's some air in the bile duct, which we expect, of course. There was a metal stent in there. And there's the bile duct. We can follow it. There's lots of artifact from the air, and now we're coming back down towards the papilla. So previously I was up at the hilum. On the left-hand side, you can see there's a lymph node there. All looks very benign. The portal vein is deep, and now I'm moving in back towards the papilla, and now you see the PD. Interestingly, here the PD is not dilated. It's actually very thin. Looks quite normal. So if I just try to turn it a little bit more towards the papilla, this is now the area of the papilla. So when you hit the duodenum, of course, you get the folds of the duodenum and you start seeing the air around it. So this is the actual region of the papilla, the far right. I don't know if with a cursor you can show it there, across here. And then now I come into the orifice here, and there's a bile duct at the top, and right below it should be the PD. Now that's a vessel, that other structure. Let me just get the plane where we can see the PD again. Oh, what happened? I lost my EOS view. Okay, here we are again. All right, so let me try. So there, that looks to me me like that little duct, that little thin thing looks like the PD right there, see? I think that's the PD. Now, you can throw some Doppler on quickly just to see, because every once in a while there's some vessels that can look like the PD, and then of course they'll light up if it's a vessel. It's not, so I think that's the PD. So it's odd, because I was expecting a dilated PD. So, now what's this thing here though? Because that, put the Doppler on this, I thought this is a vessel here, but it's not lighting up. All right, so the anatomy is a little confusing. We know where the bile duct is. We saw something that looked like that PD, is that like a branch? But then there's a structure right below it that I thought is vascular, but it's not lighting up, which is strange. Is that the PD?
I think that's initially what I thought. That was my impression.
Yeah. So the thought is that this is the PD, and it's starting to. Interesting. It's now looking like the PD, but what is that other little structure there? That one right above it. See, there are two structures, one above and one below. And it doesn't light up on Doppler, correct? If you bring the Doppler up just a little bit more to be sure, because now I'm thinking, well, maybe it's a vessel. It's just odd that you have two ductular structures like that after we identified the bile duct. Well, let's do this. Let's just pull back into the stomach, and let's get a transgastric view, because clearly, if we've got a dilated PD, as it does appear to be the case, we should be able to see it nicely on the transgastric view. Just have a lot of air in the stomach, so I just have to wait a moment till I can give you a good view. If you can decrease the mag some, we're getting there now. And indeed, this is a very dilated PD. So, and there's no, vascular signal in there. Yeah. And her pancreas looks very viable, right? I mean, she doesn't have atrophy, she doesn't have calcification, she doesn't have any changes of chronic pancreatitis. She just has this very dilated duct that goes all the way to the tail here, all the way to the tail there. And I just lost it because there's the splenic hilum. So, in the interest of time, because I know we don't have a lot of time, let's go ahead and access this duct. And so the question is, where should we access? And I like to pick a point where I'm going to shoot the needle in. What's going to happen is the pancreas will displace. I told you that the pancreas is not adherent to the stomach wall. It looks adherent when you look at it like this. But what you'll see is that when you push your needle into the pancreas, you push it away. You displace it. So you're going to have to kind of overshoot a bit. So I like to, if possible, to access the genu, because that's where it dips down into the head. And there I have sort of an extrapolation of my needle path so that I will land nicely inside of the duct. So we'll take the 19 gauge needle, and we have an expect needle here, right?
Yes.
So this is the Nitinol one.
19 flexi.
19 flex, yeah.
You're in the antrum there or in the body?
No, we're in the body. We're in the body. So now here's a few little things here. First thing is you need to pass your sheath all the way through, and because we have some ambulation at the tip, we're going to have to straighten out the scope. We're going to lose our EOS view for a moment. So now I'm engaged in the working channel, and I'm going to lock in like this. All right. And the next thing is to make sure that your sheath comes out of the end of your scope. That means that it crosses the elevator. So let's first of all start to get into position again. You can see the PD again.
Put her on her back more?
Yeah, and we can actually start to put her on her back now. So we're going to turn her a bit on her back, and we'll also get the floor into view. So you can see the sheath at the top, kind of like a double tram track appearance. You can see the two lines of the sheath. And so we're going to just make sure that that's out a bit. And then we're going to lock the thumb screw here so that the sheath does not change position. So now we got the sheath. We know the sheath is out, so we're not going to accidentally damage the scope when we advance the needle out of the sheath. We're going to just take a quick moment to turn her onto her back, and she's tubed, so we don't have to worry about aspiration. Now, if she were not tubed, of course, we would have to be very careful when moving the patient into the supine position. The other possibility would have been the prone position, but I've found many times that the prone position, you're kind of locked into that one position. It's just hard to maneuver the patient, to change the patient's position. So you can sort of, with the patient supine, you can move it up a little bit, move it back more, make the patient flatter. So it's particularly important when you're doing work at the hilum of the liver to really define the anatomy well. You need the patient in the supine position. All right, so now we've moved the patient. Now we just need to check the fluoro, and as soon as the assistants are out of the way, we'll do that. All right, so we're just going to think ahead in terms of what we need here. So one of the first things I didn't tell the assistant here is, of course, we could leave the stylet in, and we could puncture, and then when we pull the stylet out, we could aspirate fluid. The problem is you're going to have to fill up your entire needle lumen with fluid. Otherwise, if you inject some contrast, you're going to get air inside of the duct. So one thing you never want is air in the duct, because that's going to create all this artifact. So it's really better, and this was my mistake, I didn't tell the nurse to prime the needle. So we're going to take the stylet out, and we're going to prime the needle with contrast. So we're just going to, there we are, we're in good position, and just mag out a little bit if you can. I don't know if you can mag out some. So we're taking the stylet out, it's a nitinol stylet, and we're going to prime now with contrast. So I'm going to puncture the duct, and as soon as I'm in the duct, I'm going to inject the contrast. Usually you can see the needle in the duct, and then you'll immediately see some bubbles flow into the duct. And of course, when you step on the fluoro, you'll see the pancreatic duct film. Okay. So now this is primed. All right, now there's another needle called the access needle from Cook. With that needle, you have to puncture with your stylet in, because the stylet is what makes the needle sharp. So the problem there, the limitation of the access needle, is you have to be sure that you aspirate some fluid before you inject your contrast, because otherwise you're going to get air bubbles inside of the duct.
Which wire will you like to use?
And so for the wire, so the best wire to use is actually, or the wire that I use, I should assume that they're the best. But there is from Olympus a VisiGlide wire, which is 0.02. You have that, great. So so the nice thing about that wire is it's very, very stiff, but it has a smaller diameter and it's less likely to shear at the tip of the needle. The advantage of the access needle is that your wire will not shear, but the drawback I just explained to you is that you might inject some air into it. All right, so now let's just sort of take a look and see what the best spot is to target.
How many centimeters is your scope in
Scope is at about 40, 43 or so. So we can take a look on endoscopy and make sure what you're saying is very important, to make sure you're not too far up. I'm assuming I'm not, because I'm seeing the genu, but you definitely don't want to puncture through the esophageal wall. So, and then also, since we have make the endoscopy big, you can see actually that the sheath is sticking pretty far out. So the other thing you could do is, just endoscopically put your sheath right about there, just so that you barely see it. The key is that the sheath is not inside of the working channel. All right, so now you can see about the position I'm in, and now we'll switch back to the US. Okay, and now I just have to find the best spot to go for. This is the genu here. We're going to look at the trajectory of our needle, so I'm going to advance the needle a little bit forward. Like that, you can see it's very bright. Okay, you could even now measure from the tip, if you freeze and just measure from the tip of the needle to the duct. Let me do that real quickly. And just so we have an idea of the distance that we have to throw the needle. All right, so that is, what is that, about 14. Okay, so now what I'm going to do is I'm going to use the thumb screw, and I'm going to lock in about 2 centimeters from the point I'm at right now. All right, so that brings me to about 3 centimeters here on my markings, on my calibration. And I'm just going to throw this, I'm going to thrust it in. Rather, if you just try to push this, you'll just push the pancreas away. So the best way to get into the duct is to thrust it. The other thing that's very helpful is to have an assistant, somebody hold the scope, because the scope wants to displace as well. Recoil backwards, all right? So I'm just going to hold this position. You got some breathing movement, right? And I just thrust it, but I missed it. So I'm going to readjust. Okay, and at least I know how I'm what the trajectory is. Okay, I'm going to look again and what happened? Okay, so now I'm in something, but I have to look and see whether the tip is where I want it. I need someone to continue to hold this. If you don't mind just holding it for another second. Because what I'm going to do is just slowly pull the needle back. What's happening?
Something's going on with this.
Yeah, we don't want to keep losing the US image like that. Okay, I'm pulling the needle back. See, I'm really nicely inside.
Yeah, that looks great.
One moment here. I'm nicely inside. You can see I'm smack in that duct. And now we can start injecting. And you're going to see on EUS and on fluoro that we're in the duct. Okay, but 1 second here. Let me just get the fluoro ready. Okay, go ahead. And let's have the other, or somebody, okay, with the other hand. Somebody inject now. And you'll see on EUS, you should see some bubbles. See the bubbles in the duct?
Yes.
All right, and now look on fluoro and you start to see the duct fill. There it is. Very nice. Okay. Yep. Someone's going to move because we want to get a good filling of the duct. So you can see that the
So this is
all
pretty
right,
much.
filled it very nicely. And let's get our wire now, please.
This is pretty much the point of no return now, right? We filled our duct with contrast.
Oh yes. I mean, we could aspirate the contrast out. That's not a problem. But yes, I mean, right now we're going to hope that we can accomplish the rendezvous.
And a mundane question: did you give her antibiotics?
Oh yes, always.
How
You
about?
got antibiotics before the procedure.
Okay.
Okay, so as soon as you'll see the wire come out. And there it is. See it? It's very, very bright. Okay, and now we'll look on fluoro. This is the part that gets a little tricky because we have to see through the contrast here. It's kind of going into a side branch, I think.
Are you able to
Now-
use an angled wire if you need to?
Is this an angled one or not?
Not.
Not angled, yeah. Angled would be best. Okay, so trying to get a sense of why. It's interesting because on EOS it looks like it's going the right direction, but on the fluoro it's not. So obviously shear going okay, advance again. Okay, now this is the negative of this wire, is that it's stiff. Okay, so that's going into some side branch there, isn't it? Okay, let's try it again. So, oh, there it is. Okay, now it's not through yet. Not through yet. I'm stabilizing my position. You have to keep pushing. And now one of the things I forgot to do, and I'm really kicking myself, I always put a clip at the ampulla, so I know exactly, I was talking about this last night at dinner. I always put a clip on the ampulla so you know exactly where the ampulla is. And, you know, that's maybe the one instance where maybe having that stent still in there would have been good.
Can you guys center the fluoro for us?
We need like an extra pair of hands here to help us.
Oh.
So, I don't think I'm through yet, although I might be
I'm
through.
gonna move the fluoro so that.
Part of me thinks we're through, actually, we popped through. But let's see, I'm going to feel better if I see this wire moving further down more freely. Are you having resistance when you push it? Oh no, it's going back on itself, see? So there's the obstruction is more to the right side of the fluoro screen. All right? Yeah. So we're going to get the fluoro more centered, and thank you. If you can just kind of hold that scope. So one thing that you never want to do is lose your EUS view. You must keep your EUS view, because if we have to go to transgastric drainage, so we're pulling back on the wire a little bit, and we're going to try again to push through. Okay. And this is where I tell you, if you used a regular .035 wire, you probably would have sheared it already.
Other way?
Other way.
Good.
Okay.
That's it?
And maybe a little bit more over so more to the, move it to, so we want to see more of the right side. No, other way, yeah, other way, sorry, yeah, there you go. Okay, that's good. So let's try again with the wire.
Okay.
Because we're there, that's where the obstruction is.
Pushing in or going
No,
down?
no, pull back, because it's coiling on itself, right? It's going back into the duct.
I have resistance.
Have resistance. Okay. When you have resistance, then the assistant never pulls forcefully because even this wire can shear off. So what you need to do is pull your needle back a little bit, and then it'll free it up. Okay? So let's try it again.
Go ahead, Paul.
So,
Yes.
So you never try to cross the patella with a loop in the wire. It won't go, right?
I won't go now, well, no, not when it's buckling back the way it did.
No.
But yeah, you can try to knuckle it.
Forward. Go ahead, forward.
Yes,
And
yes,
you're across.
yes, I think we're across. All right, I think so. So now we need to move the fluoro just to be sure that wire, keep pushing in, because we're gonna have to push a lot of wire in. Because what can happen is that wire, when you do your exchange for the duodenoscope, your wire retracts, right? And so you could lose your wire. You have to make sure you really loop it in well in the duodenum.
Are you
At least
okay with the US?
Yeah, the US is okay, yes.
So
You just
when-
have to, that fluoro is kind of our problem here, because I want to see what's happening. It is kind of coiling there. Hopefully it's in the duodenum, I have to say.
I'm not sure.
And you have to move it over the other side. You're moving it the wrong side. Fluoro, on the other side, please.
Towards this
Yeah,
side.
towards the right side, please.
No.
Other way.
Hard to imagine you're not
Other way.
doing it.
Pardon me?
I said hard to.
No, I agree with you, but I need to have a generous slope.
Closer to us.
Okay,
And-
more over, please, so we can really, it's gotta be in the duodenum, huh? What's that contrast there? What's that contrast there, though?
and-
Something's funny here, do we have a leak going on? This is just, why are we seeing something filled with contrast?
Do you think that's an incomplete divisum?
Yes, you know, this is something weird. Because look, there's a side branch coming out filling. And now can you go back to the other side, to the left side, our left side? Because, so is this the tail end that we're looking at? This is the problem is I kind of am a little disoriented with the floral because I'm not in my unit. And I don't know, so we're moving now towards the patient's left side. So that should be the tail, right? We just moved towards the left, so that tail should be on the left side of the image. Is that correct? Because you use this unit.
Yeah, this is in the four, but the tail should be,
On the left side of the image, right?
actually, this is reversed from what we normally do. The tail is usually over here, but I believe that with this floor unit, the tail is over
Okay,
here.
but in terms of how we were moving the patient, because my concern is we're getting some leak there.
Yeah, I'm wondering if it's that one. Can you, I can't move over there, can you just put some lead on and help us with the fluoro? Lead on and help us with the
Yeah,
fluoro?
okay, so now, that's the tail now is on the right side. Right, the tail's on the right side? Am I interpreting this correctly?
That's my interpretation.
It's gotta be, right?
Yeah.
Okay, so now where is our wire going? Our wire's not going into the PD. So now we have to look towards the left side.
So, huh?
Oh yeah, I don't, gee, doesn't look right. Doesn't look right. It just doesn't look right. That's just a far distance to be from there all the way to the left. Yeah. No, I'm in PD. We can switch to Terumo. Okay. I'm in the PD, one second, let me just stabilize my position. So Michelle's in here and said, look, why don't we switch to a Terumo and take a look? Because maybe the wire punctured through something, I don't know. It just doesn't look right. I'm in the duct nicely, so we've lost nothing. Interesting, huh? Do we should inject some more contrast at this point? The problem is now we'll get the air in there, so you're gonna have to aspirate and then inject if you wanna do that. But you can get a Terumo. We know at least it's gonna be on the left side that we have to find the ampulla. It's really too bad we didn't put that clip at the ampulla.
Let's aspirate a little bit, and then we can inject one.
Forget these little things.
Just aspirate a little.
All right, so we'll aspirate a little bit of contrast, and then we can fill the duct up a little bit more to see what's. But you know, there's a little leak there you can see. So maybe it's not a good idea to fill it too much.
Okay, that's good.
Yeah, that's good. All right, so what we're doing is making sure that that hydrophilic wire, the glide wire, is well lubricated. Is it long wire? Okay. And it's 0.035, right? Okay.
Maybe you went out a side branch before you got to the extraction.
That is possible.
You want me to hold scope or pass around?
Yeah, there's definitely some meat going on here.
Mm-hmm.
So the drawback of the VisiGlide is it's stiff, so it can perforate if you push it forcefully.
Breakfast, we're in the same.
Same thing again. Where's that going?
Okay?
Where's that
Yeah.
going?
That's resistant.
Yeah.
I got it.
But it keeps going. So on EOS, you know, I'm clearly inside of the duct.
Resistant.
Looks to me like the duct. And you're going to easily get resistance here. Go in, try now, and it goes. No. There it's going that path again, right?
Yeah.
Question is that path to the duodenum? It may be. Let's see if it starts to coil down and do what looks like the duodenum. It looks like it, doesn't it?
Yep, advancing.
It looks like it.
I'm advancing.
It's okay. Let's see if we can move it down so we can see further down. This could be. It could be that the duct is just so long that the genu, the other way.
So Ken, normally you don't control the wire, your tech is controlling the wire.
Yes, because I have to keep my hand on the scope. You see, I got my hand here and here, and I don't know if you have the EOS view. Yes, you do. You see, I'm keeping my eye on the EOS to make sure I don't slip out.
So we're in that same.
We're in that same thing. What is that thing?
Yep.
It's
Well,
strange.
now it's doubling back on it. Yep.
Yeah, you want to get it in. You want definitely it's a very long stretch.
It's a long stretch or a long duct.
And on top of it,
Okay.
you have two parts. There's a dissociation and a mid-level stretch.
Okay, so that's the extension of the duct. The duct is actually there. So, all right, I'm sorry, the ampulla is actually there where it's.
You want me to keep trying to
It'd be
bring it?
nice if you could pop through there.
Should I bring it back,
A
so
little
that,
bit, yeah.
huh?
Yeah, this is more.
Bring it back a little more?
Bring back the loop. And try to train it. Pull back, pull back.
All right, and as you advance the wire a little bit forward, it's 1 to 1. I'm going to lock the thumb screw.